Sir, you are in live. Good to go.
Good evening, everyone. It's a great pleasure to welcome you all for the IPNA endorsed Webmaster Series 2020. Today we have got
Ma'am,
two
ma'am, we are
talks.
good to go live.
I've started speaking already. Good evening, everyone. It is a great pleasure in inviting everyone for the IPNA endorsed Webmaster Series 2020. And today we have got two talks. One is on hypertensive emergency and the other talk on management of hypertension. Before that, I'll be giving a brief outline on hypertension in children. So hypertension in children is on rise with the epidemic of obesity, and sometimes it is just only a first indicator of chronic kidney disease in children and adolescents. So it becomes very much mandatory in all children above 3 years of age during any medical examination, and in children less than 3 years of age when they get admitted for any serious illness. So it becomes mandatory for them to get their BP checked. And pediatric hypertension is relatively common, but it is frequently undiagnosed. And in an observational study, it has been noted that only 2 per 10,000 emergency department visits are due to hypertensive emergencies. And so we need to have a proper pediatric BP standardization, which will help us to identify whether it's an emergency, urgency, or the child requires only a routine care. So according to the American Academy of Pediatrics Clinical Practice Guidelines, it is based on the normative distribution of blood pressure in normal weight children and is stratified by the age, sex, and height. And before labeling any child as having hypertension, you should get their BP checked at least 3 or more occasions. And they have classified as normal blood pressure, elevated blood pressure, stage 1 hypertension, and stage 2 hypertension, which is a severe form. The terminology of pre-hypertension is being removed in this. So 2017 AAP clinical practice guidelines for children aged between 1 to less than 13 years of age to label a child as having normal blood pressure. The systolic and diastolic blood pressure has to be less than 90th percentile. And for children more than 13 years, the systolic and diastolic pressure has to fall less than 120 upon 80. And elevated blood pressure in less than 13 years old is when systolic and diastolic blood pressure is more than 90th percentile to less than 95th percentile, or when you have a BP recording of 120 upon 80 to less than 95th percentile, and you should consider whichever is lower. And for more than 13 years, the systolic blood pressure of more than 120 to 129 and diastolic blood pressure of less than 80. And stage 1 hypertension for 1 to 13 years old, it is systolic and diastolic blood pressure of more than 95th percentile to less than 95th percentile plus 12 millimeters of mercury, and or if the BP recording is 130 upon 80 to 139 upon 89, and you should consider whichever is lower. And for more than 13 years, when you have a blood pressure of 130 upon 80 to 139 upon 89, and stage 2 hypertension, which is a severe form, the systolic and diastolic blood pressure has to be more than 95th percentile plus 12 millimeters of mercury, or if a BP recording is more than 140 upon 90, and consider whichever is lower. For more than 13 years, it is more than 140 upon 90. So for a child with stage 1 hypertension, we actually have an ample time for evaluation and to treat the child. And most of the treatment would be non-pharmacological treatment unless the patient is symptomatic or has a hypertensive target organ damage. For stage 2 hypertension is a severe form, so it requires emergency medication and treatment. So in severe hypertension and hypertensive crisis, you have two things. One is hypertensive emergencies and the other is a hypertensive urgency. With this, I conclude and I call upon the next speaker, Dr. Indira Agarwal, who is going to talk on hypertensive emergencies. Madam is a head pediatric nephrologist at Christian Medical College, Vellore. Her special interest is in glomerular disease, tubular disorder, chronic kidney disease. She is a past president of Indian Society of Pediatric Nephrology. She is a scientific advisor to National Board Pediatric Nephrology. She is a EB member, North Arcot District IAP, and past ISN fellow, Sister Renal Program, Trio Program, and Transplant Program ISN. Over to you, ma'am.
Thank you, Kalaivani. So good evening, everybody. And first of all, I would like to thank the organizers, Dr. Namalwar and Dr. Kalaivani, for this excellent initiative in starting this webmaster series, and also to the support given by the IPNA for this current series that she has initiated. So today we'll be talking about a very important problem, which is called hypertensive emergencies, which is a very commonly encountered problem, which is seen more often in a hospital setup and often a cause of admission to an ICU. So without much ado, we shall go on to the topic. So I shall start with a brief introduction and also include a couple of cases in the course of my talk. We'll then go on to some definitions, the pathogenesis, the diagnosis, management of hypertensive emergencies, some special situations, and finally an algorithm for management. So now coming back to the definition, so hypertensive emergencies are not uncommonly encountered in pediatric practice, as I just mentioned. And many times the children might have some pre-existing cause for hypertension, or sometimes it may be the first manifestation of some underlying problem. So they may be asymptomatic and have no real past history of hypertension. It's extremely important for us to diagnose this because it is a potentially life-threatening clinical condition. But unfortunately, many times the blood pressure measurement in children is missed, and this may be for various reasons. So I'd like to just demonstrate a case which recently presented to us. There was an 8-year-old boy who actually had a tooth abscess to start with and resulted with a tooth extraction, and he was treated with antibiotics. Following this, he had some residual swelling of the neck which persisted for a few days. A few days later, he developed symptoms of headache, mild uneasiness, and some occasional vomiting. Now, this was not given much attention to by the parents. However, on the 6th day, he developed left-sided focal seizures, and there were multiple. And so he was taken to a local doctor who started on Dilantin, but didn't really investigate further. The seizures persisted, and therefore he was referred to our hospital. Came into the emergency department, had another seizure in the emergency, and at this time was noted to have persisting facial puffiness. The right-sided puffiness persisted, but this time there was even puffiness on the left side of the face. Pedal edema was present, and a very, very high BP was recorded of 160 by 110 millimeters of mercury. He also had tachycardia, gallop, and elevated JVP in the liver was 3 centimeters. Further investigation showed urine microhematuria, low C3, ASO ADNB was high. And therefore, this child was confirmed to have a post-streptococcal glomerulonephritis. But more than that, he had severe hypertension, and probably he presented as an emergency. If you notice, what the initial symptoms that he presented with headache and uneasiness could possibly have been the earliest signs of hypertension, which were missed, and therefore it resulted in further worsening of the blood pressure and development of severe hypertension. So it's extremely important that we think of measuring blood pressure, and which is something that is missed even by many practitioners. So we need to look for the evidence of target organ damage when a child presents with hypertension. And we shall come to the details of what are the different types of target organ damage. But it's important to know that when there is markedly elevated blood pressure, it needs to be reduced, especially in those in which there is emergency, so that there is arrest of this progression to end organ damage, and also to prevent life-threatening complications. In all other situations, the blood pressure may be lowered more slowly, and here oral agents may be used. This is to avoid a precipitous drop of blood pressure, and this in order to avoid hypoperfusion of the vital organs. So this is equally important. And complete examination needs to be done at the same time in order to rule out what the underlying cause of the hypertension is. So now coming to these definitions, severe hypertension was defined as 20 millimeters above the 95th centile, and this definition was given by the European group of who studied hypertension. And this is what they had suggested should be the definition for severe hypertension. Now, hypertensive crisis was defined as a sudden as well as abrupt elevation in the blood pressure from the baseline, and generally believed to be almost 50% above what would be the normal for that child, or it would be more than 180 by 120. A hypertensive emergency is a severe and symptomatic elevation in the blood pressure with evidence of some potentially life-threatening symptoms or presence of acute target organ damage, as was present in the child that I just mentioned to you. Hypertensive urgency, on the other hand, is just severe hypertension but no target organ damage, which could be thus the first initial symptoms of the presence of hypertension. Now, there was another group, Joseph Flynn et al., who met together to put together the clinical practice guidelines for screening and managing high blood pressure in children and adolescents. And they came together with a report which they published in Pediatrics in 2017. And they put forward the theory that a single term could be used, acute severe hypertension, to replace the terms urgency and emergency in reference to any acute symptomatic hypertension. They also commented on the fact that there was no clear definition for severe hypertension in children, and they suggested that a level of more than 30 millimeters of mercury, more than the 95th centile, may be considered as severe hypertension. And for example, they gave some cutoffs, like for what they said for a 13-year-old, any value more than 160 millimeters of mercury, and which is about 21% above the cutoff, or a value of about more than 135 millimeters for a 1-year-old, which is 29% above the cutoff value for that age. So as you can see, the younger children have been given a larger value for a larger cutoff value for hypertension. So this could be a guide to the physician for which we to alert them that the blood pressure is high and they need to look for complications and also treat it. Now, it is not the absolute degree of BP elevation that is important. It is more important on the effect of the high blood pressure, which is the presence of end organ damage or the symptoms that may be present due to that. The renin-angiotensin system plays a very important role in the genesis of hypertension, and we shall discuss this shortly. It is also important to assess whether the hypertension is chronic, whether it was acute, or whether it was acute on chronic hypertension. So some points regarding this: when a child has chronic hypertension, the BP may be high, but there may be no symptoms because of the presence of autoregulation. However, when the child has an acute rise in blood pressure, it may manifest with emergency, even though the BP is only mildly elevated or moderately elevated. And such children may present with target organ damage even at a much lower BP. And in such situations, the BP needs to be lowered much more slowly. And the conditions where this might occur may be in the situations of perioperative hypertension, or in children who are have undergone BMT or undergone cancer treatment. In such children, the target organ damage may occur at a much lower level, and therefore we must be ready to treat it. A precipitous drop in blood pressure can result in impairment of perfusion of vital organs, and this is something that we need to keep in mind when we are managing these children. So what are the different types of target organ damage that can occur? So the 4 main organs that are affected are the heart, the kidney, the peripheral vascular tissue, and the eye, as well as the CNS. So what are the symptoms they can have? So CNS, they might have altered mental status, lethargy, coma, confusion, seizures, irritability, facial nerve palsies, or hemiplegia. And some of these situations might mimic a head trauma or even a mass lesion, and therefore these need to be excluded because such children may also have hypertension. In the eye, one might see the presence of papilledema, retinal hemorrhages, and sometimes even more severe symptoms like even the presence of blindness. In the heart, we see left ventricular failure, pulmonary edema, S3 gallop, new heart murmurs, LVA may be present in these children. And in the renal manifestations, there may be hematuria and proteinuria, which could even mimic an acute glomerulonephritis, and therefore this also needs to be excluded. Now, what is a hypertensive encephalopathy? So most emergencies would manifest with some CNS symptoms, and when these are present, they are referred to as encephalopathy, and it may be defined when there is a severe elevation of the blood pressure with cerebral edema, And there is the presence of neurological symptoms of lethargy, coma, or seizures. So when both these are present, we call it encephalopathy. And it occurs due to cerebrovascular endothelial breakdown and also failure of the cerebral autoregulation. So what is hypertensive urgency? A hypertensive urgency occurs when there is elevation of blood pressure, but there aren't any severe symptoms and there is no evidence of target organ damage. And this warrants immediate evaluation. And because when urgency occurs, it occurs quite often from an acute cause with the rapid change in the mean arterial pressure. And in this situation, the intervention should be prompt and IV medications should be used. However, if this occurs in the setting of a chronic condition, say for example, chronic kidney disease, then blood pressure would have increased gradually over time and lowering of blood pressure in such situations can be slower. But whatever said and done, when there is severe and persistent hypertension, there are long-term consequences and these need to be borne in mind. And there is a high risk of permanent neurological damage. There's risk of developing chronic renal failure, and there's even the risk of developing a serious consequence like blindness. Now coming to the pathogenesis. The rapidity of rise of blood pressure, the degree of elevation of blood pressure, and the duration of the blood pressure increase are all important factors that can initiate a hypertensive crisis. At the same time, presence of fluid overload, sodium retention, and endothelial dysfunction will also play a role. And this BP homeostasis is maintained by the cerebrovascular system, the kidney, and it is also modulated by neural and humoral mechanisms. But by and far most is the importance of this autoregulation of the blood pressure. And what exactly is this? The autoregulation of blood pressure actually results in the stable perfusion of end organ within a range of mild to moderately elevated blood pressure. And once this blood pressure exceeds the autoregulatory zone, excess pressure is applied to the distal vasculature and then resulting in various effects like increased vascular permeability, endothelial damage, and arterial or fibrinoid necrosis. And this results in tissue edema, vasoconstriction, tissue ischemia, and then results in long-lasting damage to the various vital organs. Now this little picture actually nicely demonstrates how cerebral autoregulation occurs. Between the pressures of 60 to 120 millimeters of mercury, cerebral blood flow is maintained. And this occurs by the process of vasoconstriction, which restricts the cerebral hyperperfusion. But as and when the blood pressure continues to rise more than 120, when it reaches a critical number of around 160, this autoregulation is overcome and cerebral hyperperfusion occurs. There's autoregulation failure, cerebral hyperperfusion occurs, tissue ischemia occurs, cerebral edema occurs, and all the changes start occurring of symptomatic symptoms start appearing. However, in those who have acute elevation of blood pressure, this loss of autoregulation can occur at around 160 by 100 millimeters of mercury. In those who have chronic hypertension, this autoregulation loss occurs at a much higher blood pressure. It can be as high as 220 by 160 millimeters of mercury. So what are the effects that occur? The three main things that occur is oxidatory stress. There's a reduction in the nitric oxide, therefore inhibiting vasodilatation. The reactive oxygen species are generated and these directly damage the blood vessels. Endothelial dysfunction occurs as a result of BP elevation, renin release, oxidatory stress together, and all these cause the endothelial dysfunction. So at the end of the day, there is vasoconstriction, perivascular inflammation, and activation of the coagulation cascade. And all of these result in vascular obstruction, target organ damage, and severe elevation of blood pressure. So this slide will demonstrate how exactly this vascular or the endothelial dysfunction occurs. The very first picture demonstrates how the endothelial moderates the vascular resistance that is there in the vessels. There is the presence of nitric oxide and prostacyclin I2, which these are vasoactive amines which modulate or maintain the vascular resistance. As the blood pressure rises, and so the patient might go into a state of hypertensive urgency, at this time there is changes occur in this vasculature And there is a mild vasoconstriction occurs in order to prevent this hyperperfusion of the organs, and this results as a result of excretion of various other molecules being generated, and like angiotensin 2, there's vasopressin, there's endothelium 1 factor, catecholamines, and all these result in some changes in the vasculature but still maintain the endothelium. As the pressure rises much further, there is almost further molecules which are actually generated, and this includes the thromboxane A2, the cellular adhesion molecules, and a cascade of further increase in the catecholamines and angiotensin 2. And all these result in further changes in the endothelium, which is actually overwhelmed and is unable to maintain this vascular resistance. And this results in, initially there's vasodilatation, the number of the nitric oxide and prostacyclin also reduces, and there is this dilatation occurs of the endothelium. This results in fibrinoid necrosis due to hyperperfusion. There's also increased permeability of the endothelium, and there is perivascular edema which occurs. There's decretion of the fibrinolysis is decreased, and platelet aggregation occurs, and a DIC state occurs. So all these things result in damage and actually contribute to the end organ damage that occurs. So the three events that occur is the high vascular changes that occur, which occur due to increases in norepinephrine, which is also in the reuptake is inhibited, and this potentiates the vascular responsiveness. There's increase in vasopressin and decrease in the vasodilators, which are the kininogens and kinins and prostacyclins. There's also increased sympathetic activity, which augments the vasoconstrictive action of renin, leading to ischemia. And there's also another theory where the T cell activation also occurs. There's protein fragmentation and formation of neoantigens. And these activate the T cells, which enter the kidney vasculature, promote entry of inflammatory cells, release of cytokines. These result in vasoconstriction, salt and water retention, and worsening of hypertension. So there's some role for the T cells as well. So at the end of the day, again, there is vascular cytotoxicity, endothelial damage, and tissue ischemia. And if you were to put it very simply, there is a trigger which causes the severe acute hypertension. This results in mechanical wall stress in the vessel wall, resulting in endothelial damage, causing severe vasoconstriction, which causes tissue ischemia, which further worsens the endothelial damage. And at the same time, there is activation of the clotting cascade, and all of these result in end organ damage. Now coming to how do we proceed once there is severe hypertension. So when the blood pressure is much higher than the 95th centile, we need to evaluate for the etiology and for the organ damage, and also come up with a treatment plan. Now, what are some of the clinical clues to what could be the underlying condition? If there's palpitation, sweating, and flushing, there could be a catecholamine producing tumors. If there's exophthalmos, tachycardia, diarrhea, and weight loss, there could be underlying hypothyroidism. Abdominal palpable masses could suggest neuroblastoma, Wilms tumor, polycystic kidney disease, multicystic kidney disease, obstructive uropathies. Fluid overload would suggest either an end-stage kidney disease or an acute GN. Abdominal bruise could suggest renal artery stenosis. Moon facies, tri-hirsutism could suggest Cushing syndrome. Very important to check all the 4 peripheral pulses, and if there is a low BP in the lower limbs, there could be aortic coarctation. And if there's bradycardia, irregular breathing, and apnea, there could be brain injury or trauma. So very important to take a good history and a good clinical examination to come to a diagnosis. Examination would include checking the weight, height, and the BMI, all peripheral pulses, 4-limb BP, a good general and systemic examination. Very important to look for neurocutaneous markers and peripheral edema. A waist-hip ratio and waist circumference and obesity is just for the setting of exogenous obesity and metabolic syndrome, though these don't very commonly result in a hypertensive emergency. Also, the birth weight, poor postnatal growth rate, and a high salt intake might give some clue to some chronic underlying renal disease. Now, coming to some causes of neonatal hypertension, renovascular disease due to, and also the use of umbilical catheters or thromboembolic phenomenon could result in neonatal hypertension. Other causes are congenital renal anomalies, coarctation of aorta, bronchopulmonary dysplasia, CAH, renal vein thrombosis, renal parenchymal disease, iatrogenic fluid overload, ARPKD, tumors like mesoblastic nephroma or hypercalcemia. All of these could present with hypertensive emergencies. Childhood hypertension, we know the causes, about 60 to 70% due to renal parenchymal disease, 25% could be due to renovascular disease, commonest being renal artery stenosis. Coarctation of aorta is more commonly seen in infancy, and essential hypertension becomes more likely a cause in older children, though it is an emerging health concern and seen even in younger children in the current scenario. But rarely does it really present with a hypertensive crisis. There are also causes of hypertension in children with CKD and on chronic dialysis. And this could be due to ECF expansion, salt intake, which be more than that should be required. Maybe there's an increased cardiac output and increased peripheral resistance, high angiotensin II levels, sympathetic overactivity, hyperparathyroidism, uremic toxins, erythropoietin, non-compliance with antihypertensives, or even an endothelial dependent vasodilatation, all can cause hypertensive emergency. Hypertension in post-transplant patients also can occur due to CNI toxicity, to a thrombotic microangiopathy, or kinking of a renal artery. It could be an effect of sirolimus, high dose of steroids, fluid overload, or even severe rejection and, again, microangiopathy. Renovascular hypertension can be due to renal artery stenosis, a fibromuscular dysplasia, neurofibromatosis, tuberous sclerosis, Takayasu arthritis, middle aorta syndrome, or even Williams syndrome. So all these are the various causes which need to be kept in mind, and therefore we go on to evaluation. I won't really go very deeply into this, but the basic screen looking for renovascular causes. So we do a brief renal function test and ultrasound, and also Doppler and echo for target organ damage. If it looks more likely like a renal cause, then you could deeper into it doing renal scans, MCU, DMSAs. And if you think of an endocrine cause, then catecholamines and plasma and urine steroids may be done. If renal artery stenosis is considered, then renal artery imaging or sampling, MIBG scans, other scans, cable samples could be also done. We also sometimes look for comorbidities like fasting lipid profile, fasting glucose drug screen, and polysomnography in obese children. So these could be part of the evaluation, but can be done once the blood pressure settles. Now coming to the management, so we shall talk about the acute management of hypertensive emergencies, urgencies, and malignant hypertension. We won't really be talking about sustained or chronic hypertension today, which will be talked about by the next speaker. Now, just important before we continue to know the risk factors for a crisis to occur. The children with pre-existing secondary hypertension are more at risk, and those without a prior knowledge of underlying hypertension may also be at risk, and those who are non-adherent to therapy would also be at risk. And so when we are evaluating these children, it's important to also ask for any presence of known hypertension, any background of CKD, any genitourinary abnormality that may have been present in these children. I'm going to digress a bit and just talk about one particular condition that we normally see. Give this history. There's a 6-year-old child which had a SRNS or resistant nephrotic syndrome and was also diagnosed to have hypertension and started on enalapril. He presented with an episode of a GTCS, so he was intubated because of a worsening sensorium. However, once he recovered, he developed an irrelevant speech and was not even able to bear weight on his limbs. And he was referred here for further management. So in our casualty, he had one more episode of seizures for which he was started on antiepileptics. And EEG done was suggestive of bilateral epileptiform discharges. And an MRI was done because of the multiple seizures along with an MR angiogram. And this is what it showed. I'm sure you're familiar with this condition. It's showing bilateral, asymmetrical gyral swellings and hyperintensities, as well as symmetrical posterior thalamic hyperintensities. 1 month later, the same MRI was done and everything had all disappeared. There was resolution of everything. So diagnosis, no prizes for guessing, we're all familiar. This is a posterior reversible encephalopathy syndrome. So I just thought I should mention this because it's often encountered in children with hypertensive encephalopathy. And so where does stress occur? In situations of hypertensive encephalopathy, it occurs when there is cerebral hyperperfusion, endothelial dysfunction, microvascular injury, and cerebral edema. And these can be picked up by imaging studies. Now, it occurs due to vasogenic edema, and most often it occurs when the hypertension is acute. It can even occur at a lower blood pressure. It is not really, especially in the acute situation, not necessarily associated with the level of blood pressure. And often there's a trigger. And in some conditions where the pre-existing hypertension is present, it can also occur in those children who are on immunosuppressive drugs, that is children on treatment for post-transplant, or children on steroids for some oncological conditions or cancerous conditions. Also, certain autoimmune diseases and vasculitis, or those with renal insufficiency, can also present with hypertensive crisis and stress. So endothelial dysfunction and nitric oxide depletion is proposed to have occurred. Now, the symptoms can also vary. It can be just mild symptoms like just a headache and some altered status, or mild drowsiness, to altered mental status, headache, and seizures. The recovery also is usually complete, but in occasional situations, there may be some mild neurological deficits like slurring speeches or involuntary movements, which we have seen in some of our children. Now, coming to the actual management of these children. So there are several steps involved. The very first and most important thing is confirming the elevated blood pressure, and this should be done by the auscultatory method once it has been picked up. And in some ICU settings, intra-arterial monitoring is also done. The next thing is to establish the severity of hypertension. And for this, you need to focus on the history, a good clinical examination, and also look for signs of target organ damage. We also need to exclude other causes of hypertension, which might have a different mode of management, where the primary cause needs to be addressed rather than concentrating on the antihypertensives. And here this is due to hypertension, which may be due to pain, due to raised ICP, due to an intracranial mass or injury, coarctation of aorta, or even accidental ingestion of sympathomimetics. Now there are two steps again. One is to treat the emergency. The second is to treat the underlying cause. So if the target organ damage is confirmed, then the emergent reduction of blood pressure has to be done with IV medication, and it has to be started as soon as possible. And the choice of medicine may depend on what the underlying cause is, and that would be the next step, is to treat what the underlying cause. Now you also at the same time need to plan for long-term management, which needs to be introduced at the same time at an appropriate time. And agents that need to reduce blood pressure can also cause salt and water retention, and therefore diuretics may also have a role in the management. Continuous infusions are better than bolus infusions, because boluses would again cause the risk of precipitous drop of blood pressure due to hyperperfusion, resulting in hyperperfusion of the organs, and therefore there can be ischemia to the organs and long-term sequelae. So the initial goal is a reduction of the blood pressure and not really normalizing the blood pressure. That can be done slowly over a period of time. So most often when there is acute hypertension and hypertensive emergency, these children are managed in an ICU setup. And here we need to use rapidly acting agents. These also need close monitoring to avoid this precipitous drop of blood pressure. So it is best managed with a continuous infusion. So because these short-acting drugs can be titratable, and therefore it can be adjusted if the blood pressure falls too rapidly. So it does help in this correction of blood pressure and helps reduce the cerebral perfusion and prevents the propagation of further injury. Intra-arterial access for invasive monitoring can be done if there's an ICU setup which is able to monitor it. Generally, the sublingual and IM route is avoided because of this unpredictable pharmacodynamics and again precipitous drop of blood pressure. The usual rule that is followed is the rule of quarters, where they say that 25% of the blood pressure should be reduced over next 8 hours. Out of this 25%, about 10% can be reduced over the first 30 to 60 minutes. And the blood pressure is aimed to be brought somewhere between the 95th to the 99th centile. So when we are planning the treatment, we should actually set up our goals and manage accordingly. Also, another point to remember is that before starting IV therapy, assessment of the volume status is extremely important, because in case they are volume depleted, restoration of the volume, intravascular volume with IV saline is important, because this again restores the organ perfusion and prevents a precipitous fall of blood pressure. And now, once the BP is stable and end organ effects have ceased, then oral therapy can be initiated. Again, the choice of drug would depend on the preference. Sometimes it's the physician's prerogative to choose, but they also keep in mind the rapidity of action of the drug that is to be used, how safe it is, how easy it is to use, and therefore targeted therapy may be attempted depending on what the underlying condition is. Now, some of the common drugs that are used are labetalol, nicardipine, phenoldiazepam, which may be the preferred drugs. Sodium nitroprusside, also very commonly used in acute pulmonary edema, in severe LV dysfunction and aortic dissection. Clonidine and ACE inhibitors are long-acting and not very well titrable, so better used in urgencies rather than emergencies. And phentolamine and trimethoprim or catecholamine-induced hypertensive crisis it is a very specific indication to be used in these conditions. Now, coming to the more in detail these drugs, so sodium nitroprusside, very commonly used drug, quite cheaply available, has a very rapid onset of action, and it reduces both the preload and afterload. It is both an arterial and venous vasodilator, beneficial in CCF, especially that may be induced by hypertensive crisis. However, it requires some precautions where we need to often cover it from sunlight, as it is very light sensitive. So often it is covered by a black carbon paper is what we used to use. And after 42 or 72 hours, there's risk of, because there's accumulation of thiocyanate, there's a risk of cyanate toxicity, and therefore it has to be withdrawn and another drug has to be added on. Now, labetalol is another drug which we are now using more and more in clinical practice, both the alpha and beta sympathetic blocker. It reduces the peripheral vascular resistance. It has a relatively long half-life. However, it has a negative inotropic effect on the heart, and therefore contraindicated in the presence of bronchial asthma and the presence of CCF. And this is something very important to keep in mind. It should also be used in caution in children who have brain injury, because it can cause severe hypotension. It can also worsen hyperkalemia. But the advantage is it can be given both as an infusion and as a bolus. And therefore, it is more and more coming into practice. However, it is a little more expensive than compared to sodium nitroprusside. Another very useful drug is IV nicardipine, but however, it's not available in our country freely. It is the oral form which is more well available. It's also a group of a calcium channel blocker, the dihydropyridine, and it reduces the peripheral vascular resistance. The advantage is it has no negative inotropic effect. So it can be used in asthma, hepatic and renal failure, and also in presence of CCF. It is well tolerated and can be used for a long period of time. It has a half-life of 10 to 15 minutes, and also onset of action takes time. It takes 10 to 15 minutes. It can cause tachycardia and flushing, but it can be used as a first-line therapy. Phenoldiazepam is a selective dopamine receptor agonist, which has an affinity to alpha-adrenal receptors. It has a very good safety profile, can be used in renal insufficiency, very rapid action, because it increases renal blood flow and induces natriuresis. However, it is not available in our country. Then we have hydralazine, which is a very potent arterial vasodilator, acts very quickly in 10 minutes, lasts for 2 to 4 hours, has an advantage of being given IM as well as IV as well as oral. It can be used in neonates as well, in whom enteral administration may not be possible. However, it causes reflex tachycardia and sodium retention. Then we have another drug, which is a transdermal nitroglycerin, which is not a first line except in situations where there's myocardial ischemia. And it has the advantage of increasing the perfusion of the myocardial vessels. And therefore, it is used in specific situations of myocardial ischemia. It is a venodilator, and it reduces the preload and cardiac output. But it also has side effects of methemoglobinemia, hypoxemia, reflex tachycardia, and tachyphylaxis. So now, once these drugs have been used in the first line, we should also think of adding on the oral medications. And this is done when the child is conscious, when the BP is reasonably controlled. And usually this is within 24 to 48 hours of adding the infusion. Now coming to hypertensive urgency. So this is a situation, as we said, which when there is no target organ damage, but there's always a possibility that this could progress to a hypertensive urgency, from an urgency to an emergency, if the BP is not brought down within the next 12 to 24 hours. So blood pressure has to be reduced much more quickly than it is in the presence of an emergency. So here oral drugs are preferred. Nifedipine can be used, but in the past it used to be available as a capsule, which was used sublingually. But this can cause a precipitous drop in the blood pressure. So it is better used in the tablet form, which can be given orally, which has a slower onset of action only after 10 to 15 minutes. And therefore it brings down the temperature, the BP within about 45 minutes to 1 hour. But however, it can cause some cardiac arrhythmias and some problems. So some caution has to be maintained. Now, clonidine is another good drug which has a short, rapid onset of action, which is a centrally acting alpha-2 adrenergic agonist, and can be used. It decreases several sympathetic output. It can cause some dryness of mouth and sedation, and this sedation is the reason why it is not used when there is hypertensive emergency, because of its effect it can delay the recovery from neurological complications. Labetalol is a useful drug, can be given orally as well as as a IV infusion, which can be calculated in a kg per hour. It can also be given as a bolus, as a 0.2 to 1 mg per kg per dose, and can be repeated every 5 to 10 minutes. Some other drugs that are available, but not many of them are freely available in the market. You have an IV preparation of an ACE inhibitor called enalaprilat, which is useful in high renin hypertension, but it can cause hyperkalemia and AKI, and therefore not given in renal artery stenosis. Can be used in neonates, which is a physiologically high renin status, but some caution has to be maintained. And also caution should be used if there's volume depletion. So also captopril, which has a short half-life of 6 to 8 hours, rapid onset of action in about 15-20 minutes, can be used in neonates where there is high renin hypertension, but not so well advised in chronic hypertension. Then you have esmolol. This is used in an ICU setting. Often it's a short-acting cardioselective beta-1 adrenergic blocker. It helps to decrease the blood pressure quite quickly over the next 4 to 6 hours, and often used in a pre-op state when a child needs to go for surgery. Can bring down the pressure rapidly. Isradipine is a second generation dihydropyridine. It has the advantage over nifedipine that it has has a lower risk for the unpredictable drop in BP, and it acts by causing vasodilatation and without any effect on the myocardium. However, again, isradipine is not available. Diuretics can be used in volume-dependent hypertension, especially when there is glomerulonephritis or CCF, and it causes good diuresis and natriuresis. However, it also causes hypokalemia and volume depletion, and this should be kept in mind. Now, this this table just shows the different doses that can be used and the onset of action, and what are some of the side effects that they cause. As you can see, the rapid action drugs are sodium nitroprusside, glyceryl trinitrite, and phentolamine, whereas labetalol and hydralazine and enalaprilat take a longer onset but have a longer duration of action, and some of these side effects are mentioned. So if we were to summarize the hypertensive crisis, if there's a hypertensive emergency, use an IV infusion. If there's a hypertensive urgency, the child may be able to tolerate oral drugs. So you can give an IV. If he's not able to tolerate, then you can give an IV infusion or a bolus. And if they are able to tolerate, you give oral drugs. In the first 6 hours, decrease the BP by 25% of the planned BP decrease. In the next 24 to 48 hours, decrease it further and try to bring the blood pressure down to the 95th centile. And after that, beyond 48 hours, try to bring the blood pressure down even below the 95th centile. And by this time, the oral drugs would have been added and the IV drugs can be withdrawn. So the choice of antihypertensive the first line would still remain uncertain. There's no clear-cut drug that is advocated. It would depend on what the etiology is, what the underlying clinical condition is. It's also good to remember that some causes of secondary hypertension may be due to overproduction of renin, and these may be responsive to ACE inhibitors. So in CKD patients, ACE inhibitors are quite useful. They also reduce the proteinuria. And in the presence of cardiac dysfunction, also ACE inhibitors are useful because they help to improve the left ventricular function. Now, just to mention a few drugs which might help in situations where target organ damage has occurred, and therefore the choice of drug may be chosen according to the clinical condition. If there's aortic dissection, then beta blockade and labetalol is a good drug. Sodium nitroprusside may also be used. When there is hypertensive encephalopathy and cerebral infarction or hemorrhage, I've already mentioned it. Any other drug like nitroprusside, labetalol can be used, but it is better to avoid clonidine. When there is myocardial ischemia and infarction, I suggested that IV glyceryl trinitrate can be used, and beta blockade can also be used. But when there is heart failure, then beta blockers should not be used, best avoided. But diuretics and ACE inhibitors can be used. When there is renal insufficiency, diuretics should be given with caution, but calcium channel blockers are probably very easily used. And in the setting of eclampsia, which we don't really deal with, hydralazine is a good drug. So in glomerular nephritis is one of the most commonly encountered conditions. Here the acute glomerular nephritis occurs due to an acute rise in BP from a normotensive state. So there's a very high risk for press as there's very little time for resetting the cerebral autoregulation. It requires a faster lowering of blood pressure to ensure that there's minimal risk to the organ perfusion. So that also needs to be kept in mind. Because there is salt and water retention, so diuretics can be very useful. However, ACE inhibitors are not recommended in this situation because the high risk of developing hyperkalemia, and AKI in this setting of salt and water retention might actually worsen. What do we use in the newborn? Majority of medications are not approved. So we actually recommend to use IV infusions or short-acting hypertensives, antihypertensives. So amongst those that can be used are nitroprusside, labetalol, nicardipine, clonidine, and hydralazine. These are the drugs that are suggested. And we can also, ACE inhibitors, captopril can be used, but should be used with caution because it can cause some degree of ischemia and hemorrhage, and some situations has even caused death. Now, when there's hypertensive crisis in a child with ESRD, if the child is in CCF, then inotropic agents with vasodilators can be used. If there is, in some situation, even emergency UF and ultrafiltration and dialysis may be required. So that may be the more definitive treatment in children with ESRD with hypertension because it may be volume related. If they are unstable, then we may need to resort to CVVH. And if the child has residual renal function, then high dose furosemide might have a role. So generally, we use a much higher dose of furosemide. And in acute GN, as I already mentioned, with severe hypertension, diuretics may be used. So coming to now, almost the last few slides, we have an algorithm for the treatment of hypertensive crisis, and this is just a summary. When you have a hypertensive emergency, we resort to IV drugs, nicardipine if available, and otherwise labetalol to be avoided if there's hyperkalemia and acute heart failure. Sodium nitroprusside is also another drug that could be used, but monitor for thiocyanate toxicity. Phenoldiazepam not available, but hydralazine can be used as a next line of drug, and by this time we should start adding the oral drugs. When there is hypertensive urgency, the nifedipine, oral drugs like nifedipine, clonidine can be used. Minoxidil has been actually suggested to be a good drug if blood pressure is not coming down easily, and furosemide also can be given. Now, before I end, just a word about the prognosis of children with hypertensive crisis, which this needs to be kept in mind. And this actually highlights the need for actually picking up hypertension in time and treating it in time. So the outcome will depend on the duration of hypertension, the extent of the end organ dysfunction, the appropriateness of the acute therapy that was used, the degree to which BP was controlled after managing the crisis. So what are some of the consequences? So all the systems may be involved. In the cardiac, they might result with LVH, congestive cardiac failure, hypertensive, cardiomyopathy might result. Neurological consequences may be seizures, persistent facial palsy, hemorrhage, breast, altered state of consciousness. The renal manifestations might include a hypertensive nephropathy and result in some long-standing damage to the kidney. They also may be AKI, they may be proteinuria, and in some cases even development of CKD. Visual disturbances could be also quite severe. Some of them may result with blindness or quite severe retinal bleeds. So these should be kept in mind when we are managing children with hypertension, which is acute and severe. The long-term prognosis may also depend on the long-term BP control, and therefore this is also important. And with good control, even LVH and retinal angioplasty can become reversible. So that's also can happen in some cases. So the best prognosis is actually if the blood pressure was not long-standing and if appropriate therapy has been given and the underlying disease is something that can be treatable. So my take-home message is that hypertensive crisis is an acute emergency that can result in target organ damage and hence requires immediate and judicious management. Determining the cause may guide the management and will help to avoid compromise of the perfusion of vital organs. If chronic hypertension is well managed, morbidity and mortality from a hypertensive crisis can be reduced. The choice of antihypertensive should be based on the primary etiology of hypertension, and intravenous infusions are required to adequately control blood pressure when severe hypertension is present. Thank you.
Thank you, ma'am. It was an excellent and fabulous talk. You have covered almost leaving no questions for the viewers. Almost all questions are covered. Next speaker is Dr. Sriram Krishnamurthy. Next speaker is Dr. Sriram Krishnamurthy. He is an additional professor, Department of Pediatrics, JIPMER, Pondicherry, a prestigious institute, and his academic interest is on glomerulopathies, acute kidney injury, CACUT, nephrocalcinosis, and urolithiasis. He is a working group member for ISPN guidelines on HUS and nephrotic syndrome. He has a lot of publications, 21 original articles in PubMed and in indexed journal. He has won the best oral presentation at ISPN Con 2014 and ISPN Con 2016. Over to you, sir.
I thank the organizers for the invitation. And my talk will be on management of hypertension in children. So the specific learning objectives are to understand the management of hypertension in children through clinical case-based scenarios, to comprehend the etiology of hypertension in children in order to enable optimal management strategies, and to decide the choice of antihypertensive agents in various clinical case-based scenarios that I'll be talking about. So nowadays, hypertension is defined as per the clinical practice guideline for screening and management of high blood pressure in children and adolescents, given by the American Academy of Pediatrics. And according to this, 4 terminologies are used: normal blood pressure, elevated blood pressure, stage 1 hypertension, and stage 2 hypertension. These have replaced, for example, the elevated blood pressure term has replaced the previous term pre-hypertension. And the stage 1 hypertension is now defined as 95th centile to 95th centile plus 12. And stage 2 hypertension is defined as more than 95th centile plus 12, instead of the previous 99th centile and 99th centile plus 5 respectively. In children more than 13 years, that is adolescents, elevated blood pressure will be defined as 120 by 80 to 129 by less than 80. Whereas stage 1 hypertension would be 130 by 80 to 139 by 89. And stage 2 hypertension is more than 140 by 90. So when one sees these guidelines, these pediatric hypertension guidelines are an update to the 2004 fourth report on the diagnosis, evaluation, and treatment of high blood pressure in children and adolescents. And the significant changes in these guidelines include: number 1, replacement of the term pre-hypertension with the word elevated blood pressure. Some new normative pediatric blood pressure tables have been mentioned based on normal weight children. There is a simplified screening table for identifying blood pressures needing further evaluation. And a simplified blood pressure classification in adolescents more than 13 years has been provided, which aligns with the AHA and the American College of Cardiology adult BP guidelines. And in addition to this, this also mentions a more limited recommendation to perform screening blood pressure measurements only at preventive care visits. And there is an expanded role for ambulatory blood pressure monitoring in these guidelines. They also mention revised recommendations on when to perform echocardiography in the evaluation of newly diagnosed hypertension children. And this is generally only before medication initiation. These are the simplified blood pressure values that have been provided in these AP guidelines for screening purpose. So how do we approach a child with hypertension? So we can classify hypertension into transient or intermittent hypertension and persistent hypertension. When one sees the causes of transient hypertension in children, you can see that the list is quite long, but the more important ones are post-infectious glomerulonephritis, drugs such as corticosteroids, cyclosporin, even some cough syrups contain some sympathomimetic agents. Then raised intracranial pressure, Guillain-Barré syndrome, transverse myelitis, porphyria. These are some of the very important causes of transient hypertension. Besides this, any acute kidney injury, hypervolemia can lead to a transient blood pressure elevation. On the other hand, when we see the causes of sustained hypertension in children, the causes could be either renal, or it could be vascular, or endocrine, or central nervous system causes. Among the renal causes, some of the very important ones are renal scarring because of, say, recurrent pyelonephritis, chronic glomerulonephritis, for example, FSGS, congenital dysplastic kidneys, hypoplastic kidneys, polycystic kidney disease, any obstructive kidney disease such as a posturethral valve or an SLE. Among the vascular causes, coarctation, renal artery stenosis, fibromuscular dysplasia, renal vein thrombus, neurofibromatosis, vasculitis such as ANCA vasculitis or polyarteritis nodosa or Takayasu arthritis. Among the endocrine causes, 11-beta hydroxylase or 17-hydroxylase defect, or else an apparent mineralocorticoid excess. One of the most important causes is a Cushing syndrome, which is often iatrogenic in nature, and then a pheochromocytoma. And among the central nervous system causes, intracranial mass or obstructive sleep apnea. When one sees the etiology of hypertension in children as per various age groups, you notice that from 1 to 6 years, the causes are dominated by renal parenchymal disease and renal vascular disease. Although other causes like endocrine causes and coarctation of aorta and essential hypertension do exist, dominated by renal parenchymal and renovascular. From 6 to 12 years, renal parenchymal disease dominates as the cause, followed by other causes like essential hypertension, renal vascular disease, endocrine causes, and coarctation. And from 12 to 18 years, we observe that suddenly essential hypertension becomes the most common cause. Nevertheless, we should always rule out any secondary hypertension such as renal parenchymal disease or renal vascular disease or coarctation. What is the distribution of causes of hypertension in the literature? So this is one of the very large studies in which 636 children with sustained significant hypertension were enrolled. And they observed that renal parenchymal diseases make up about 68%, and renovascular diseases make up about 10% of the causes. So together, the renal parenchymal and renovascular causes make up about 78% of all the hypertension in children. The rest of the causes in the study included endocrine in about 11%, and about 75% of the adolescents, it is important to note, that they had essential hypertension. So as you become an adolescent, essential hypertension tends to dominate the picture. So with this, I'll start a series of some 7 cases in which I would like to illustrate the various causes of hypertension that we have encountered in our clinical practice, so that it becomes more illustrative. So we start with case 1. This is a 5-year-old boy who presented with a cola-colored urine periorbital edema, and mild oliguria for 3 days. There were multiple pyodermas over the skin 3 weeks ago, and the blood pressure was found to be 110/78, which qualifies as stage 1 hypertension according to the AP clinical parameters. Next, a urinalysis was done. So there were red blood cell casts. There was 1+ albuminuria. And the urinary protein creatinine ratio was found to be 1.1, which is in the subnephrotic range. And the estimated GFR was 68. The ASO was 150, but the C3 was low. And the serum albumin was 2.9. So what is the cause of the hypertension in this case? What is the diagnosis? So I think it would be very clear that this turned out to be a post-streptococcal glomerulonephritis, and that was what was thought initially. And we managed him with intravenous furosemide and oral nifedipine. Later, the hypertension was persistently high, so amlodipine was added. The edema subsided on IV furosemide, and gradually he lost weight, and the fluid overload subsided, and the blood pressure came back to normal. At an 8-week follow-up, when this child was followed up, C3 was found to be normal. And the eGFR had improved from 68, you would recall initially, to about 104. And the blood pressure had normalized by this time, and the child was taken off all the antihypertensives. And there's nil albuminuria on follow-up, but 6 red blood cells are there in the hyper field, which may persist. In microscopic hematuria is known to persist in a post-streptococcal glomerulonephritis for quite some time. It can take many months, many years. So the diagnosis of PSGN in this case was established because of the features of acute nephritic syndrome, along with the clinico-serological evidence of recent streptococcal infection. Although ASO was normal in this patient, it's important to recall that its sensitivity is low since it binds to the skin lipids and therefore it's not released in the circulation. This child had a low C3, which normalized on a 6-week follow-up. And this is considered one of the very important features of diagnosis of PSGN. So what antihypertensives do we use in PSGN? This case was a PSGN. So let us see which antihypertensives are recommended. So you have salt restriction and loop diuretics as the cornerstones of management. And thereafter, treatment with vasodilators is preferred. Initially, we may give oral nifedipine. And if the hypertension persists for some time, then you may decide to add a calcium channel blocker that is long-acting, for example, amlodipine. AC inhibitors are not recommended during the acute phase due to decrease in the glomerular filtration rate and the risk of hyperkalemia. In hypertensive emergencies, as we saw in the previous lecture, you would recommend usage of sodium nitroprusside or labetalol infusions. So after seeing a case of post-streptococcal glomerulonephritis, we go to the second case. This is a 7-year-old boy who presented to us in 2015 January, 5 years ago. And at that time, he presented with fever for 2 days, 7 days prior to presentation. And he had pallor with decreased urine output for 5 days. There was no diarrhea, dysentery, rash, or jaundice. On examination, he had edema and he had signs of intravascular fluid overload. His blood pressure fitted in with stage 2 hypertension, that is 150/100. There was no hepatosplenomegaly. The hemoglobin was found to be 4.1. And he had thrombocytopenia. 63,000 was the platelet count. There were schistocytes about 3%. The LDH being extremely high, 4,500 units per liter. And the reticulocyte count was very high. The blood urea was found to be 210, and the serum creatinine was found to be 4.9. And he had severe hyperkalemia, which was managed in the emergency with the usual hyperkalemia protocols. He was given a trial of salbutamol, calcium gluconate, and insulin dextrose. The urinalysis showed 10 red blood cells per hyper field, 2+ albuminuria. And he was started on hemodialysis since he had signs of intravascular fluid overload and hyperkalemia. Further investigations revealed a direct Coombs test negativity. Chest X-ray showed no consolidation. The coagulation profile and the liver function tests were normal. The stool for sugar toxin PCR was negative, and HIV, HBsAg, HCV was negative. The C3 was found to be low, and the ANA and dsDNA were negative. And he required multiple hypertensives during the acute phase, including amlodipine, atenolol, prazosin, and clonidine for blood pressure control, along with hemodialysis, which helped in reduction of his blood pressure. So in this case, what would be the diagnosis and what would be the cause of hypertension? I think it's very clear that this looks like a case of hemolytic uremic syndrome. And we ordered a factor autoantibody, which was found to be extremely high, 8,500 arbitrary units per ml, normal being less than 150. And over the next 1 month, he required 17 sessions of plasmapheresis and about 10 sessions of hemodialysis, along with all those antihypertensives that I mentioned in the previous slide. And then he was managed with immunosuppressive therapy very aggressively, IV cyclophosphamide pulses, and then mycophenolate with prednisolone for 2 years. So today, about 4 years later, serum creatinine came down to 0.89 milligram per deciliter, which fits in with an EGFR of 79 and corresponds to a CKD stage of stage 2. He continues to be hypertensive. He has been requiring multiple antihypertensives, amlodipine, atenolol, and prazosin, and he has concentric LVH, but no retinopathy. So now a target organ damage also has occurred with the form of concentric left ventricular hypertrophy. And albuminuria has been persisting. So on follow-up, the urinary protein creatinine ratio has been found to be high, and enalapril has been added. So the enalapril has been added especially because he is now a CKD stage 2 and has a persistent albuminuria, in which setting enalapril is considered the drug of choice. And now on follow-up, he is found to have no proteinuria, and the HUS activity is in remission. And we have even observed that the concentric left ventricular hypertrophy has reversed. So this is the AAP clinical practice parameter guideline, which mentions that children and adolescents with chronic kidney disease, hypertension, and proteinuria should be treated with an AC inhibitor or an ARB. And this is a strong evidence, which is what we followed in this particular case. So what is the role of echocardiogram in hypertensive children? So the AAP recommends that echocardiogram be performed to assess cardiac target organ damage, including LV mass, geometry, and function at the time of consideration of pharmacological treatment of hypertension. And LVH should be defined as an LV mass more than 51 gram per meter to the power 2.7 for boys and girls. For children and adolescents older than 8 years, or an LV mass of more than 115 grams per body surface area for boys, and LV mass more than 95 grams per body surface area for girls, and that a repeat echocardiogram to be performed to monitor improvement or progression of target organ damage at 6 to 12 month intervals. So in this child, the enalapril helped in cardiac remodeling, helped in control of blood pressure, and also helped in decrease of the proteinuria. So enalapril is especially a drug of choice for proteinuric CKD, especially stages 1, 2, and 3. From stage 4 onwards, we can use it, but then we should be very careful about hyperkalemia and then a further reduction in the GFR. It's not recommended in end-stage renal disease unless the patient is on dialysis. Now we go to case 3. After seeing a PSGN and an HUS, we go to the case 3. This is actually a 9-year-old girl who presented with periorbital and pedal edema for a week. And she had a red-colored urine with oliguria noticed for 4 days. She had been growing well and was asymptomatic with no history of pyoderma, pharyngitis, rash, or arthritis. And her blood pressure was found to be 140/90, which corresponds to stage 2 hypertension. And again, she had a very severe acute kidney injury, AKI stage 3, with serum creatinine of 5.2 and a blood urea of 196. And the urinalysis showed red blood cell casts and 2+ proteinuria. So I'm sure by now you would have guessed that this looks like a case of rapidly progressive glomerulonephritis. The serum C3 was found to be low, and the ECG and the fundus were normal. What does the X-ray show? It shows a pulmonary edema. And then the CT cranium showed evidence of stress with hyperintensities in the occipital lobes. So this is actually a case of RPGN, and the cause of hypertension in this case is a severe acute kidney injury because of rapidly progressive glomerulonephritis. And what could be the cause of rapidly progressive glomerulonephritis, and what could be the cause of low C3? So a rapidly progressive glomerulonephritis is a rapid decrease in the glomerular filtration rate of at least 50% in the setting of a glomerulonephritis. And histopathologically, it is characterized by 50% or more crescents. In this case, the approach would be to see whether it is type 1 RPGN, type 2, or type 3. This girl had a low C3, and so it's very likely to be a type 2 low C3, which includes either PSGN or lupus, or it could be a cause like membranoproliferative or C3 glomerulonephritis. So a renal biopsy was done, and it showed a crescentic glomerulonephritis. You can see crescents in the picture. Along with that, the vessels show severe onion peel appearance. That is, the tunica media became very hypertrophic. And because of this, the biopsy was also postponed for some time because the blood pressure was not well controlled. And the biopsy shows evidence of C3 deposits. So it is actually a C3 glomerulonephritis presenting as a rapidly progressive glomerulonephritis. And this child required initially a nitroprusside infusion in the ICU, and we couldn't control it. We couldn't give it for a long period because of the risk of methemoglobinemia. And during this period, we got some time to start on oral antihypertensives like amlodipine, prazosin, atenolol, clonidine. Later, she even required minoxidil. She required 8 sessions of hemodialysis over the next 2 weeks, and then 3 daily methylprednisolone pulses, followed by 6 monthly cyclophosphamide pulses, along with oral prednisolone, which was gradually tapered. And so the final diagnosis in this case is an RPGN due to a C3GN. And you would see that in such cases, it is possible that you will require multiple antihypertensive agents along with hemodialysis with good ultrafiltration removal for control of hypertension. And then definitive treatment would be immunosuppressive therapy, without which we cannot expect a good control of hypertension because it's not the definitive cure then. So the follow-up in this case, the serum creatinine decreased gradually, and it came down and to an EGFR of 105. The EGFR improved so much, and at the end of 3 months, and there is no proteinuria. And gradually, she was taken off all the antihypertensives for the 4th month. But then for the C3GN, we have started her on mycophenolate and oral steroids. So till now, we have seen a case of PSGN, then a case of hemolytic uremic syndrome, and the third being a rapidly progressive glomerulonephritis. Now we go to case number 4. This is a 2-year-old male child who was referred for evaluation of an incidentally detected hepatomegaly. His height was 87 centimeters and the weight about 11 kilos. The development was normal for age. There was stage 2 hypertension, the blood pressure being 120 by 80, and the echo and the fundus were found to be normal. On examination, he had bilateral kidneys palpable, and the spleen was also palpable. Then an ultrasound was done that showed massive nephromegaly bilaterally. So the right kidney was about 5.1 Z score, and the left kidney being about 5.5 Z score with increased echogenicity. So in this setting, what would we consider? We went ahead, we did an MRI, which showed massive nephromegaly, and there was also intrahepatic cystic dilatation suggestive of Caroli's disease. And then the further course showed a liver biopsy showing a congenital hepatic fibrosis, and there was also evidence of Caroli's disease. And the child underwent an endoscopy showing an esophageal varices grade 3. Fortunately, she did not have hematemesis. The serum creatinine was normal for age, 0.32, and the EGFR was normal. She was started on enalapril. Later on, it was not so well controlled, so other antihypertensives were also required, being amlodipine, atenolol, and thiazides, on which the blood pressure has become well controlled. So what is this? This is actually what appears to be the cause of hypertension in this case. You have massive nephromegaly Along with that, you have hepatomegaly, splenomegaly, esophageal varices grade 3, Caroli's disease, and congenital hepatic fibrosis. Obviously, it's a case of autosomal recessive polycystic kidney disease, Caroli disease, and congenital hepatic fibrosis. And this was later confirmed with PKHD1 mutation. What is the mechanism of hypertension in ARPKD? So hypertension is very common in ARPKD. It develops in about 80% of ARPKD, and it can start from any time from infancy to adolescence. And it can occur even in the presence of a normal renal function. So it is not necessary that the child should have a renal dysfunction in order to have a hypertension. So it is believed that the renin-angiotensin-aldosterone system may play a very important role as a key regulator of blood pressure in these cases, as a result of which enalapril has been often considered standard of care. Some of these children have volume overload, and that can contribute to hypertension, but this predominantly occurs in a setting of a poor estimated glomerular filtration rate. Overall, enalapril has been considered standard of care. There is a controversy in these children about the usage of amlodipine because it's a CAMP agonist. And it is believed that in animal models, it has been shown that the cyst size can increase with amlodipine usage, but this has never been translated into human models. So amlodipine has been used by many clinicians successfully in the literature. Other drugs that can be used in these settings are beta blockers, and thiazides have been especially recommended if there is a concentrating defect, for example, if the patient has a polyuria. Now we go to case number 5. We have 2 more cases after this. So case number 5 is actually a 5-year-old girl who was evaluated for referred for evaluation of a dilated cardiomyopathy after she presented with a congestive heart failure elsewhere. And she was found to have blood pressure of 180 by 120 in the right upper limb. And the physical examinations were very significant because we observed that there was a left carotid, brachial, and radial pulses. They were all very weak, and there were bilateral carotid bruits. So a renal ultrasonography with Doppler was performed, and this showed a renal artery stenosis. The serum creatinine was normal, and the urinalysis was normal. The urine did not show any active sediment or proteinuria. ESR was 80, and the CRP was also very high, 27. This girl required multiple antihypertensive agents. Initially, she required drugs like amlodipine, prazosin, hydrochlorothiazide, carvedilol, clonidine, and later minoxidil. So she has required multiple drugs. And later we went ahead to the angiogram, and you can see that the angiogram of her brain, chest, and abdominal vasculature was performed, and this revealed significant narrowing of the left common, external, and internal carotids of the bilateral, subclavian, hepatic, splenic, and renal arteries. And there was an asymmetric kidney size, and there was diffuse thickening of the aorta from the heart throughout the abdomen, right wall signal. So a diagnosis of Takayasu arthritis was established. And the diagnosis of Takayasu arthritis is basically made on basis of the Euler-Printo-Press classification for the criteria of childhood Takayasu arthritis. And this girl fulfilled criteria in the form of angiographic abnormalities. Plus, you require only one of the 5 criteria, but she fulfilled all of them. She had a pulse deficit. She had a 4-limb blood pressure discrepancy. She had a hypertension more than 95th centile, and she had acute phase reactants. So the further management of this child, because there was an ongoing activity, she required methylprednisolone pulses for the persistent inflammatory activity. And later she was started on mycophenolate prednisolone. And as I mentioned, she required multiple hypertensives. In renovascular hypertension, you may require actually multiple antihypertensive drugs for control. It's not easy to control also renovascular hypertension. And enalapril in this case should be avoided because there was a bilateral renal artery stenosis. If you use it, enalapril in bilateral renal artery stenosis, the creatinine will worsen and the child will go into acute kidney injury. Later, she underwent a balloon angioplasty of the renal arteries. And now this has led to better control of hypertension, although she is still requiring 2 antihypertensive drugs. Gradually, the steroids were tapered. Our second last case, this is actually a 14-year-old girl who presented with excessive weight gain and progressive swelling of the lower limbs for a month. And she had stage 2 hypertension at admission. She denied any drugs, traditional medicines, or steroids. And her face was very typical for a Cushingoid appearance with extensive acneiform eruptions. She denied taking any steroids. The weight was 50 kilos at 0.06 Z-score, and the height was 151, which is at minus 1.56 Z-scores. Her mother revealed that the weight was only 43 kilos a month ago, which means she gained about 7 kilos in a month. And there was no discrepancy in the forelimb blood pressures, and all the pulses were palpable. The serum creatinine was 0.54, which is normal for age. Urinalysis was also normal. But the blood gases were very remarkable for a hypokalemic metabolic alkalosis with a bicarb level of 45.7 and potassium also being 2.8, which is very low. So the echocardiogram was shown to have a concentric LVH, indicating that the hypertension was of either a subacute or a chronic origin. And the serum cortisol was done because this girl had Cushingoid appearance. She denied taking any steroids, and the cortisol was beyond range, beyond the reference values. It was very, very high. And then an ACTH was done, which was also extremely high. So this suggested that she had an ACTH-dependent Cushing syndrome. So the MRI showed no evidence of pituitary or hypothalamic lesions. And to pick up where the ACTH is coming from, a CT abdomen was done. And this showed a hypodense, poorly enhancing lesion in the tail of the pancreas. So you can see in the picture, the tail of the pancreas, you have some hypodense lesions. And she also had some metastasis in the liver. And then a distal pancreatectomy specimen, a distal pancreatectomy was done. And it showed a well-circumscribed pancreatic neuroendocrine tumor. And this was what was producing the ACTH. So this case is actually a case of endogenous Cushing syndrome due to an ACTH-producing pancreatic tumor. So normally, the most common cause of an endogenous Cushing ACTH-producing tumor is a pituitary tumor, which is there in 75% of the cases. But in the remainder, you can have any other organ involvement, like the adrenals, the pancreas, and some other tissues are also reported. So what is the mechanism of hypertension in this patient? It is actually a mineralocorticoid action exerted because of the supraphysiological levels of cortisol. So when the cortisol levels are extremely high, it stops behaving just like a glucocorticoid. It starts having a mineralocorticoid kind of action. And the mineralocorticoid receptors, as we know, they exist in the distal nephron, and they can get activated by this cortisol. Normally, this cortisol leading to mineralocorticoid activation, this is actually this is kept in check because of an enzyme called 11-beta hydroxysteroid dehydrogenase. But when there is a cortisol excess, the level of cortisol will exceed the capacity of the 11-beta hydroxysteroid to inactivate to cortisone. So the conversion of cortisol to cortisone will not be able to occur. And the cortisol is in so much supraphysiological doses that it binds to the mineralocorticoid receptor and it mimics excessive aldosterone. What is the mechanism of hypokalemic metabolic alkalosis in this case? That's because the high cortisol acts on the mineralocorticoid receptor, and this leads to the ENaC channel activation, and this leads to excessive sodium reabsorption, And the mineralocorticoid receptor activation also stimulates the ROMK channel on the luminal side. So you get a potassium loss in the urine, and this hypokalemia is accompanied by a metabolic alkalosis. What is the management in this particular case? This girl, before we knew that she is actually an endogenous Cushing, she had been started on multiple antihypertensives. She required many of them, amlodipine, atenolol, and prazosin. But later we added spironolactone, which is actually would be the drug of choice in this particular case, because it would bind to the mineralocorticoid receptors. And this led to a transiently better control of hypertension. But then again, the basic cause was there. So till the distal pancreatectomy was done, the hypertension was not resolved. After the pancreatectomy was done, the hypertension resolved. Later, she has been started on chemotherapy for the pediatric, for the pancreatic neuroendocrine tumor. And now she is on follow-up for chemotherapy with our oncology colleagues. And now we come to the last case. This is actually a 7-year-old. This is the case number 7, a 4-year-old girl who was incidentally detected to have hypertension during a health camp visit, with her blood pressure being 125/86, which corresponds to stage 2 hypertension. And she had a weight of -1.1 Z score and a height of +1.2 Z score. She had no edema, anemia, headache, or vomiting. There's a past history of recurrent fever without a focus, and this used to resolve with some antibiotics, but she never had a urine culture done, ever. People used to give her antibiotics, the fever used to subside all the time. And then ultrasound KUB was done, which found that the left kidney was hypertrophied with a +3.12 Z score, and the right kidney being atrophied with a -4.76 Z score. So the serum creatinine was 0.35 milligram per deciliter. That is normal for age. And the urinalysis did not show any hematuria, pus cells, or proteinuria. So basically, we have found out one cause, that the left kidney is compensatory hypertrophy because of the right kidney being atrophied, but there was no hydronephrosis. An echocardiogram was done, which was normal, but the fundus showed a grade 2 hypertensive retinopathy. This is the DMSA scan of the child. This shows a small right kidney and the function being only 18% of the total function. And there is a defect in the left upper pole medially. There are photopenic areas. So we proceeded with the next investigation, which would be actually an MCU. And the MCU showed a bilateral vesicoureteral reflux, with the right kidney having a grade 5 reflux and the left kidney having a grade 3 reflux. This case did not have hydronephrosis, and it is very well known that the ultrasound findings do not often correlate with the MCU findings. So what is the mechanism of hypertension in this particular case? That is a reflux nephropathy with renal scars. So the renin-angiotensin system is implicated in the genesis of hypertension and reflux nephropathy. And the plasma renin has been found to be high in many studies in these cases. And so the drug of choice would be actually enalapril. So this is the preferred antihypertensive. You could even consider an ARB, for example, losartan. This child was also started on quatrimoxazole prophylaxis because of the reflux nephropathy. So after these 7 cases, I think you would have got an overview of what kinds of cases present in pediatrics with sustained hypertension. And so the questions are, how do we approach a child with hypertension? And how do we investigate or evaluate hypertension in children? And what is the role of ambulatory blood pressure monitoring? And what are the various management strategies available? So briefly, I'll be covering, because some of these areas have already been covered in the previous topic. So basically, you have to always, in any hypertensive patient, clinically look for all the peripheral pulses, whether they are palpable or not, and always record a 4-limb blood pressure. These are some things that you should never miss on clinical examination. Then other things would be any short stature, obesity, truncal obesity, any Cushingoid facies, Elfin facies. These are all very important clinical findings, which can give you a clue to the cause of the hypertension. Next would be any cafe au lait spots or signs of tuberous sclerosis, These can be associated with neurofibromatosis or tuberous sclerosis, and these are known to be associated with, for example, neurofibromatosis would be associated with renovascular hypertension, and tuberous sclerosis can be associated with the angiomyolipoma or a polycystic kidney disease complex. A malar rash, an abdominal mass, an epigastric or a frank bruit, palpable kidneys, ambiguous genitalia could be actually pointing towards the 11 beta hydroxylase deficiency, or you could have a vesicoureteral reflux features, history of recurrent urinary tract infections. These are some of the important findings that you should always look for in these children. If they have hypokalemia along with hypertension, then it could suggest either a renovascular hypertension, or else it could be a Little syndrome or a reninoma. Well, the laboratory tests that we do in children with hypertension would be to identify the cause, in which you could do complete blood counts, blood urea, serum creatinine, electrolytes, renal ultrasound, urinalysis, or a urine culture as clinically indicated. You could identify comorbidities by doing fasting lipid panel, fasting glucose, insulin, etc. You could identify the end organ damage by looking for echocardiogram or a retinal examination. And additional tests would be depending on the clinical features of the child. For example, if there's a massive tachycardia, then you could consider a urine or plasma catecholamines. Or if you have a pulse discrepancy, etc., then you would go for a renal Doppler, you would go for a CT angiogram or a digital subtraction angiogram. The AP also mentions certain high-risk conditions for which ambulatory blood pressure monitoring may be useful, and these include secondary hypertension, CKD. All children with CKD have been recommended to undergo an ABPM. All diabetic children, whether type 1 or type 2 diabetes, obesity, obstructive sleep apnea, aortic coarctation, and genetic syndromes like Williams syndrome or neurofibromatosis or Turner syndrome. These have been recommended to have a ambulatory blood pressure monitoring. The drugs for hypertension, which drug to use is a matter of controversy in many circumstances, but certain things are very clear that, for example, in children and adolescents with CKD, hypertension, and proteinuria, they should be treated with an AC inhibitor or an ARB, and there is strong level of evidence regarding this. And in hypertensive children and adolescents who have failed lifestyle modifications, particularly those who have LV hypertrophy on echocardiogram, or a symptomatic hypertension, or a stage 2 hypertension without a clearly modifiable factor, for example, obesity, we should initiate pharmacological treatment with the AC inhibitor, ARB, long-acting calcium blocker, or a thiazide diuretic. The treatment goals are to bring down the blood pressure, systolic and diastolic, to less than 90th centile, and less than 130/80 in adolescents more than 13 years old. This is actually a grade C moderate recommendation as per the AP. And according to the results of the ESCAPE trial, it has been found that in CKD children, as per ambulatory blood pressure monitoring, it should lower the 24-hour map to less than 50th centile by ABPM. And this would be actually renoprotective in these children. The drugs, according to our ISPN guidelines, could be actually you start with a CCB or an ACEI or a beta blocker, but obviously you will have to follow the necessary contraindications in various scenarios. For example, in an acute kidney injury or a bilateral renal artery stenosis, you cannot use a AC inhibitor. Similarly, a beta blocker you would not prefer in a heart failure. Later, if the blood pressure persists, then you can use combination therapies, and various combinations like AC inhibitors or calcium channel blockers, or AC inhibitors with thiazides, or a beta blocker with a calcium channel blocker can be used. And later you could use even more various combinations such as AC inhibitors, calcium channel blockers, prazosin, beta blockers, or thiazides. And then choose additional agents like clonidine, labetalol, hydralazine, and minoxidil as applicable. The drug of choice for hypertension also depends on the etiology of hypertension. For example, in essential hypertension, you could choose an AC inhibitor or a calcium channel blocker. Later, you could choose a beta blocker also. But thiazides are generally not preferred in obesity because they can lead to a metabolic syndrome with the glucose intolerance happening and uric acid levels rising, etc. So thiazides are not preferred in these situations. Beta blockers would not be preferred in an impaired glucose tolerance or in a known asthmatic patient, for example. Acute glomerulonephritis, our drug of choice would be furosemide. If required, later we can add a calcium channel blocker, but we would not use AC inhibitors in this situation. In CKD stages 1, 2, and 3, especially if the patient is proteinuric, we would prefer enalapril. If the patient has a renal scar, then we would choose enalapril as a drug of choice. If the patient has a pheochromocytoma, then we would use a catecholamine blockade, for example, phentolamine, prazosin, phenoxybenzamine, and later we could consider beta blockade as an adjunct once the blood pressure is reasonably well controlled. So my take-home messages from this class are: hypertension in children is commonly of renal and renovascular origin. Studies reporting up to 80% of all the hypertension in children being of either renal or renovascular origin. And you should always look for target organ damage in children with hypertension in the form of concentric left ventricular hypertrophy, retinopathy. Do a proper urinalysis in these children that can help you pick up the cause of hypertension in many cases. Serum creatinine, urinalysis, ultrasound of the kidney, ureter, bladder, the renal Doppler, DMSA, CT angiogram, or digital subtraction angiography as clinically indicated would be useful for evaluation of these children. The treatment goals are generally a systemic blood pressure or a diastolic blood pressure less than 90th centile. But in CKD, we should target 50th centile by the ABPM. We should, on the 24-hour map, we should target the BP close to the 50th centile, less than the 50th centile. And enalapril is actually a drug of choice for CKD stage 1, 2, and 3, especially. In stage 4 and 5, we use it with caution. Unless the child is on dialysis, it would be very difficult to use in our setting. And a prompt and correct antihypertensive usage is essential for optimal control and providing good outcomes to the patients. Thank you. I finished on time.
Thank you so much for taking us into an array of clinical scenarios, starting from the common PSGN, HUS, RPGN, ARPKD, and even the ACTH producing tumors. It was a complete clinical scenario. It was very good, sir. Can we take up the questions? There are a few questions from the participants. A very common question. Like you have already mentioned in CKD, the salt restriction has to be 1.5 grams per day. But in general, what is the sodium intake and does it contribute to hypertension in general population with no underlying illness?
I think we'll be having classes on CKD in the future sessions. And I think we need not go too much into this right now.
There's no simple answer to this. I think, yeah.
And is there any specific drug for steroid-induced hypertension?
Withdrawal of steroid.
Going to be only a transient hypertension. Is there any specific drug of choice for steroid-induced hypertension? Probably we'll go on for the short-acting one, like amlodipine or something like that.
Yeah, yeah. There's no order of antihypertensive as such in this situation. Definitive would be to choose a steroid-sparing agent as soon as possible, taper off the steroids, and consider usage of a calcium channel blocker.
And very disease-specific question: is there any specific drug for HUS causing hypertension? Because they present with severe hypertension, is there any specific drug to be used in HUS other than the routine medications?
There's no specific agent. Again,
probably we'll run into the series of all antihypertensives and end up with clonidine, minoxidil, everything.
There's only one drug that should not be used, enalapril, during the acute phase.
Yeah, because already a child would be having pre-existing AKI.
AKI.
And the other is it routine to check ABPM for all patients with hypertension?
I mentioned some clinical scenarios in which ABPM has been recommended, and one of them is CKD. Then type 1 and type 2 diabetes mellitus, obesity. Certain conditions have been mentioned in the AP,
Okay.
prematurity. It's not
Okay, the question is already been partially answered. Already this question is also like, we don't have an answer probably. How do we choose medication? Which group of medicine? Is there any first line of drug? Probably depending upon the disease status, we have to choose our antihypertensives. Say for renal artery stenosis, you can't use bilateral renal artery stenosis. We can't use ACE or ARBs. Probably it is disease specific.
But the algorithm was given, so that is a suggested algorithm. ISPN has suggested it's, I mean, one can follow that basically.
ISPN guidelines for hypertension. Okay. I think that's it. Is there role of? I think it's not it's a very irrelevant question. They have asked, is there a role of ultrasound in hypertension? Probably all the answer has been already given. Other than in ACTH producing tumor, other than spironolactone, is there any other drug of choice to be added, which will really help in bringing down the mineralocorticoid action?
Tumor should be removed. Otherwise, hypertension will not get controlled.
Okay. So the etiology has to be treated.
Yeah.
Fine. I think we had an excellent clinical discussion, starting from talk of hypertensive emergencies and moving on to the clinical scenarios. Everything was an excellent session. Thank you so much, ma'am. Thank you so much, sir. It was an excellent clinical series. Thank you. Thank you so much. The next session will be on September 19th on enuresis and avoiding disorders. You can stay tuned on September 19th.
Thank you.
Thank you.
Thank you, ma'am. Thank you, sir.
Thank you.
Chetan. Hello, Chetan.
Yes, sir.
Chetan, we can close it now.
Okay.
We can
Close
stop
कर दो इसको?
Yeah.